Okay, well, I want to welcome everybody again. And first up, we've got several panels for you today. And our first panel today comes from the federal perspective. And I'm going to just do a quick name introduction. I'm going to let them do the fuller background in terms of their expertise and let them answer an initial question as they introduce themselves. So starting at the far end, we've got Megan Cow from the Office of Minority Health at CMS. Next to her, we have Christy Clark from the U.S. Public Health Service and CDC. And then we have Kelly Cronin from the Administration for Community Living at HHS. And then Joanna Henry with the Office of Policy at ONC. And so I'm going to let you guys go down the line, but I'll start here with you, Joanna, to do a better introduction of yourself if you wish to. But I would like you to touch on and talk about what is your agency doing and from a data technology standards perspective to address the health disparities in underserved communities.
Great, thank you so much. And as you mentioned, my name is Joanna Henry. I am the Interoperability Systems Branch Chief within our Office of Policy at the Office of the National Coordinator for Health Information Technology. And within that office, what we are working on is Trusted Exchange Framework and Common Agreement. And then what my office also works on, and why I'm here today, is social determinants of health and health equity. The question is what our agency is doing kind of in that space around data tech standards to address health equity. And one of the first things that we're doing is aligning with the Biden and Harris administration and HHS's plans to promote health equity. And we're doing that by advancing interoperability in healthcare, data standardization, and network connectivity at scale. And so one of the things at ONC is that we do recognize the potential of health IT to mitigate and help in eliminating widespread health disparities within the U.S. health and healthcare system. But we also recognize that health IT cannot address all societal and institutional factors that drive health disparities. So one of the things that we're pushing for and promoting is really how do we use health IT to mobilize health data, IT to identify and mitigate health disparities, and not allow that health IT to actually perpetuate the health equity gaps in the U.S. today.
Thank you. So Kelly, do you want to introduce yourself a little bit more and speak to the same question about data, technology, standards being used to address health disparities?
Sure, and you want this to be like a brief overview? Okay.
Sure.
Okay. Yeah, I'm just trying to, I'm not sure. Okay. Yeah, Kelly Cronin, great to be here and see many friends of many years, June and Ross and Linda and many others. So I'm at ACL now. I've been there for 5 years. I'm a deputy administrator, and I direct a Center for Innovation and Partnership. So ACL, in case folks aren't familiar, is one of 2 human service agencies in HHS. We fund a lot of community-based organizations across the country in what we call sort of an aging and disability network, sort of networks of community-based organizations nationwide. Roughly 20,000 we reach through states that then pass down funding to area agencies on aging, and other centers for independent living are also independently funded by us. So there's a sort of a broad network of CBOs that we try to reach to really be able to deliver comprehensive services that address the social needs and other needs of older adults and people with disabilities. So just for context, so we are on the social service, human service side, so much of what we do is really related to SDOH. And the data that we collect generally is from states, so it's aggregate. We do have some direct grantees, like through our Medicare grant programs, we support a lot of Medicare beneficiaries with access to their benefits, whether it's their low-income subsidies or helping them on just their options with Medicare or navigating Medicare. So with those programs, we do have a lot of sort of data that comes from those individual counseling sessions and through helping them with various types of benefits access. And in those programs, we have done equity analyses where we are trying to understand how do we reach the most, the populations most in need. So we look at diversity and a variety of sort of subpopulations to identify who are we not serving and how do we better target them. So, for example, in some of our initial analyses, we've found that Native American Indians and people in rural populations need to be better served. They're underrepresented who we're currently serving. Or in some cases, like in Miami-Dade, in certain counties, we know we need to better reach the Latino communities or others. So we are trying to use a data-centric approach to really trying to better serve populations that need to be better reached. Generally speaking, though, from a technology perspective, we don't have a lot of direct funding, unfortunately, to support technology adoption in the social services world. However, we are trying to support the growth of CBO's capacity to be able to be partners to healthcare, to be able to receive ADT alerts, to be able to do bidirectional exchange, integrate into HIEs, be able to figure out how this emerging world of information referral can be better integrated into their existing business operations. They've been doing information referral for decades. It's in our authorizing statute. It's not anything new. So in human service, there's been INR for many, many, many years. But now that there's sort of a new class of technology vendors, they haven't really necessarily integrated with all those legacy systems, right? So one of the things we're supporting that EMI and others are organizing for us is a state collaborative to try to help state leaders in various parts of state government, whether it's a state health IT coordinator, Medicaid, human services, whoever is working on information referral systems at a state level, get them together and help them together learn how they can achieve interoperability across an increasingly complicated INR space. So what's the state strategy? What can they do from a policy, technology, and assistance perspective? In some places, like in Maryland, it's an easier strategy, perhaps, because there's such a mature HIE with CRISP. And one of our other projects that both there's actually two leaders here from our area agency for aging in Maryland that's acting as a community care hub for the whole state. They are working with CRISP on a really neat project that MITRE is also organizing for us called and it's coming from CDC. It's coming from a CDC investment in the Clinical and Community Data Initiative, which is an open source tool that was originally developed for a variety of public health use cases in Denver and North Carolina. We're now adopting or implementing it in Maryland with a focus on how to support clinical and community integration and looking at what happens after somebody's discharged from the hospital and they have nutritional needs, food insecure, they need food or other supports. Well, what happens after their discharge and what does that look like over time? What are the outcomes? So ultimately we're thinking Cody could be the kind of tool that CBOs haven't necessarily had the financing to support on their own, but this could be a collaborative way through the HIE community to build out an open source tool where you could look at the outcomes of people that receive both health and social care over time. So you can visualize what's happening and be able to understand the value of the social care in addition to what their clinical care is. So there's that on the technology side. On the standards side, we've invested, I'm sorry, I'm probably going a little long here, but standards side, we, as an agency, we don't have like a lot of direct funding to support standards. We do collaborate with ACF and ONC on what will be sort of a human services data interoperability strategy, and looking potentially to develop a human services part of like the U.S. core data for interoperability. So there's some early planning and discussion around that through a social care referral challenge that we launched a couple years ago. We encouraged people to implement the Gravity Project standards, human services data specification, and have some real-world experience with that. Some of our challenge participants, the Missouri Data Collaborative in particular, really had some great progress with that. It was one of our winners. But we are looking to try to build from what came out of that challenge to inform what happens with U.S. core data moving forward for human services, and specifically the aging and disability core data set. So we supported in the last 2 years the development of a FHIR implementation guide that would allow for exchange between community resource directories. We recognize there's not only a lot of historical data in 211s and in the networks we fund that have really been coming from public and philanthropy, funded efforts, but now with a lot of market activity in the last 5+ years, there's a lot of private sector efforts that are building out these community resource directories, often with their own proprietary taxonomies. We recognize on the federal side, we need to have a strategy to get to open taxonomies and not a lot of different proprietary ones on top of the 211 LA taxonomy. We've had a sort of an ongoing dialogue and convening around how do we do that? How does federal government work with others to get to open standards, including taxonomies in this space? That's an ongoing challenge and dialogue. But specifically what we also funded, which I started to mention, is the implementation guide for these community resource directories. So we don't have a lot of siloed resource directories that can't share data with each other. So ultimately this should be information that should be exchangeable. If somebody is hungry, if somebody needs behavioral health peer supports, somebody needs housing supports, that data should be shared. It shouldn't be just in one proprietary platform. At least that's the goal of having this interoperability is to make sure that those resources are readily accessible to anybody who needs to try to retrieve them or try to use them. So that's a quick, or maybe a little long-winded description of what we're doing.
So Christy, we'll move to you next.
Hi, everyone. Great to be with you today. So my name is Christy Clark. I'm the Senior Advisor on Data for Health Equity. A little bit of background about myself. I'm a pediatrician. I've been at the CDC for over 12 years in a variety of capacities. Probably to the best introduction to what I'm going to talk about today is that at the beginning of the pandemic, I was reached out to by a mentor, asked to lead the team within the COVID-19 response of CDC that was tasked with trying to understand the impact of and where possible mitigate the effects of COVID-19 on a variety of disproportionately affected populations. So specifically, our populations of focus were people experiencing homelessness, people experiencing incarceration, people with disabilities, older adults, as well as people who use drugs or have substance use disorder. So I led that team for about a year and a half until that task force was stood down in the process of streamlining the response. And the big challenge, which was echoed by all the presenters this morning, was the data. I mean, certainly within all of those populations, one can see that there are significant data gaps and challenges, and it was really clear that this needed more of a systems approach. So I work to be the connection between our health equity scientists, SMEs, and the technical side of the house, the people who are working to build systems, make systems level decisions, specifically because it became incredibly apparent to me during the pandemic that when populations are overlooked in the design of public health data systems, they end up being underserved in public health practice. And so that is my mission in terms of what our organization is doing. Briefly for that question, first, just streamlining the data modernization process. So that's now centered in a new office that was established immediately under the Office of the CDC Director, which is the Office of Public Health Data Surveillance and Technology, and that's where I sit. And specifically what we're doing in our vision is very publicly and clearly outlined in our public health data strategy. It's currently out now. It's going to be updated every year with a 2-year vision and milestones and specific things we're going to be meeting. There's going to be a new revised version for this year that will be released within about the next month or so. I asked and got permission to give a little bit of a preview to the health equity related elements of this new strategy, which I'm really excited about because I think they really show a holistic and integrated version of equity. So first of all, increased emphasis on social determinants of health and really integrating that into our analyses, dashboards, and products. Both those that are able to collect those as well as those that are able to pull those in on a geographic level. And then with electronic case reporting, which is basically there's a notifiable disease diagnosed, and rather than having to go into a whole other system as a clinician to report that, it's automatically pulled out and it's sent along to public health authorities. We're not only working to increasingly connect as contributors our critical access hospitals, but also we're looking at the receiving side and looking at data equity and data sovereignty issues in terms of making tribes and tribal epidemiology centers more so able to directly receive information and data about the health of their populations.
Okay. So move on to Megan. And Megan, during the prep for this panel, you mentioned something about some CMS standards that might be coming out related to disparities. So I don't know if there's anything you can share there or not.
Good morning. My name is Megan Cole. I am in the Data Analytics and Research Group within the CMS Office of Minority Health at CMS. As some of you may know, in this morning's presentation, CMS, we oversee the Medicare, Medicaid, and CHIP in the marketplace. So there is a lot going on at CMS from a rulemaking perspective, a data collection perspective, health equity, burden reduction, interoperability, so on and so forth. So for this morning, I am going to selfishly only speak about some of the initiative we do in our office. We don't own any data program, but we do advise the administrator in across the different components in terms of program coordinations. How do we implement or embed health equity across the different programs that as the different colleagues, right, do rulemaking, right, they don't lose sight of the different aspect of health equity that needs to be addressed. So from a data perspective, we are continuously identifying data gaps and figure out how to improve our data collection. As some of you may know, self-reported data is the gold standard. And a lot of time we don't have self-reported data. So a number of initiative has been happening within the office and the CMSY in terms of collecting self-report data, especially at the disaggregated level. We're trying to avoid proxy data because only you and you would know how to identify yourself, right? And nowadays, by looking at somebody, you can say that person's X, but they may be Y. And that does have an impact on care. Additionally, we're also trying to explore options to collect SOGI data. So for this 2024 open enrollment period, we started to collect SOGI data, sexual orientation, and gender identity data on the marketplace application. But as we continue to explore the opportunities for better social demographic data, there's the standardization aspect of it, right? If I'm collecting one thing, Christy's collecting another, and then Kelly something else, like we can never analyze the data at the end of the day because we're all working from different aspect of the standards. So one of the things we're trying to do is see how we can start a baseline of standardization across what we call the health equity data elements, which are the ones that are listed in the executive order, advancing equity, so such as race, ethnicity, SOGI, disability, geography, so on and so forth. And Nancy, I was hoping that I could share some of the news. However, it is still going through our clearance process, as some of you may know, it takes forever. However, I will put in a plug that we will be hosting a health equity conference May 29th to the 30th in Bethesda at the Hyatt Regency. It is, I think, soon open for registration soon. So we will be sharing a number of data initiative as well as some of the other CMS health equity projects that are happening. So I want to put a plug in there for you all to check it out. The website is CMS Health Equity Conference and all the information is there. We're also looking forward to the OMB's revision on race and ethnicity, right? Hopefully, it'll be more at the disaggregated level than what they currently have at the 5 categories of race and 2 categories of ethnicity. We continuously get requests for disaggregated level data collection, but we can only work so far based on what we currently have. But the one thing, as we're talking about standardizations, interoperability, HL7, FHIR, so on and so forth, I don't want to lose sight of the fact that a lot of the data collection is still on a paper-based form, or individual coming to a center asking for assistance to help out, right? So we need to do cognitive testing. We need to make sure the individual understand what the question and the answer are, especially for SOGI. And so I don't know how, as you all work on the interoperability aspect, is everything being collected and being interoperable is cognitively tested? So then an individual who doesn't understand English well know what we're asking for. Or here, I don't know if this is true, but I've heard like individuals from Hungary, they don't have aspect of male and female. So if we're asking a SOGI question from an individual from that country, will they know what exactly we're asking and what we're trying to collect the data for, which goes to the question is, what is the federal government doing with my data, right? So we need to be more transparent in terms of why we're collecting the data, what we're using the data for, or how we're using it. But a lot of that are considerations that CMS is looking into as we continue to improve our existing data collection or collect new data just to make sure we capture the diversity across our underserved population. And then there's a lot in the area of SDOH, looking at collecting health-related screening social needs. But then how do we address the fact that we're collecting the data at multiple points for the same individual? So how do we address the security aspect, the privacy aspect, the burden aspect, and making sure that we're doing something with the data that we're collecting? So a lot for CMS to consider as we continue to look more into the data gaps, using the current technology, how do we standardize it? And then, of course, the latest conversation is AI, which is a lot happening in that space. So join our Health Equity Conference in May.
Thank you. So we've talked a lot about data, and we've been hearing the word data quite a bit this morning. The other word that we've heard a bit more is community. So I'd like to touch on just how community relationships are being built. And Joanna, I know that from an ONC perspective, you're thinking interoperability, but how do you think about community in terms of the work that's going on there? And I understand there's some work that you, within ONC on site visits.
Yeah, so we do quite a bit of things at ONC, and I just want to kind of go back and do an overview of what some of those things are. I think first and foremost, we are working to guide the development and dissemination and adoption of SDOH and health IT standards. We do work in the space of informing policy development to overcome some of the challenges that we have for SDOH interoperability. We also do work in the space of supporting public and private partners who are really building those infrastructures to actually have SDOH interoperability. But we also have programs where we're driving innovation in care delivery to really see that SDOH interoperability in the workflow. And then one of the things kind of like Megan mentioned is that we're also working to improve the capture of equity-sensitive data. So that's like race and ethnicity, just across the various levers that we have as far as standards adoption. And this is evident in some of the programs that we have, which is our certification program, our health data technology and interoperability one final rule, which really highlights our use of US CDI version 3, which includes those SDOH data elements. And we have a couple other things going on. So then the question is, where's that role of community and that collaboration? There activities that we do around those other things that includes having those workshops and webinars to engage our community partners and our collaborators. We also have our Health IT Advisory Committee that has the opportunity to engage us in some of those activities that we have going on. We also have public comment periods for some of the standards that we are developing, and to your point, we also have site visits. And these are site visits for some of our programs that are working on some of these innovations for interoperability. And that includes our leading edge acceleration projects, our public health IT programs, also known as our FIT programs. And so what that looks like is as we are going to different seminars and workshops like this, we're sharing what we do generally with ONC, but this is also an opportunity for us to have site visits with some of our partners, so some of our federal health qualified health centers that we are working with. Being able to sit face to face with them and have conversations and hear about some of the challenges and some of the good things that are going on with the technologies that they're using through these innovative things that we are developing. For our FIT program, we are advancing the workforce with that program. So what that looks like is being a guest lecturer, attending graduations, being able to sit with those students and talk about their experience as they are going through some of these training programs to really learn about these standards that we're asking to be used in the industry.
So Kelly, I know you mentioned some different efforts with different, North Carolina, Missouri. It sounds like you've got a good community outreach built within the work that's being done through ACL. Is there sort of any lessons learned from, like, what's a great way to build those relationships, or is there any advice you can offer there?
Sure. I mean, I think a lot. A lot of what we do as an agency is around community partnerships, and also really centered in person-centeredness as well. So not only community focus, but also I think having that culture of person-centeredness for all your community partnerships is also helpful, in that you're always trying to do better for that individual and improve their experience, whether they need support as a diabetic, not only with their doctor, but also to know how to manage their diabetes and eat properly and exercise. They need all of those wraparound services to be able to thrive and live a good life. But generally speaking, when you're bringing a lot of different people together at a community level, healthcare, CBOs, public health, other partners, technology partners, for everybody to really be there for the individuals you're trying to serve, first and foremost, is, I think, an important sort of grounding principle. But also thinking about the overall health of the community, and how can you really be grounded, and how do you want to thrive as a community? What are your goals? What are you trying to do? And in an efficient way as possible. If there's a lot of siloed activities in a community, or if every healthcare partner has their own technology solution for community interventions, then you're not thinking about scale or efficiency in your investments or your workforce. So I think we really have tried to embrace also equal partnerships is a big piece of this. Shout out to June Simmons in the audience, who you're going to hear from, I think, this afternoon or tomorrow. She's not only the CEO of Partners in Care Foundation, but also the co-chair of the Partnership to Align Social Care, which we have helped support the evolution of, which is really a way to bring a lot of healthcare leaders and community leaders all together around a common vision for a social care delivery system where CBOs and healthcare organizations can be equal partners within a community and across communities. How do you build out those partnerships so it's not just one dominant healthcare system or health plan that has a strategy for addressing health equity and social needs, but how do you do that at a community level in equal partnership with the community-based organizations that have so much trust in the community? They know the populations they're serving, they're culturally sensitive, they know the language, they know what matters. They can be welcomed into people's homes. They can provide the wraparound services. They're great extenders to the healthcare team, but they need to come together as partners. So much of what the Partnership to Align Social Care has been doing over the last few years is trying to get to agreement on how all does that work. And specifically, we're working very closely to try to scale the model of a community care hub, where you can have a community-focused entity, like a CBO, be able to provide a network or develop a network of community-based organizations that can address transportation needs, housing needs, nutrition needs, social connection, evidence-based programs that will help them be independent and healthy in the community, a spectrum of supports that all are, in keeping with what matters to the individual and what's consistent with their clinical care. So all of that is work that we are supporting through grants, through a Center of Excellence to help soon administer grants to help these community care hubs, infrastructure grants. They'll be coming out in the coming months. But also we have a lot of technical assistance to sort of support this successful community partnerships based on all these things I'm mentioning. So we have a really big investment. It's not just ACL. We're working really extensively across the department. And one example of how our collaboration has matured in recent years across HHS is a call to action to have community partnerships come together to address health-related social needs through all stakeholders contributing. So what should be the role of health IT technology organizations or HIEs? We've called out, ways for them to participate by adopting standards, by, taking action and working with your local CBOs or providers. So the roles for everybody to play in both on the community side and the healthcare side. So we have really been trying to nurture those community partnerships, not just individually through our agencies, but really as a department, trying to say this is not just about federal government, state government, local county government. This is about all of us coming together to make this work.
Great. Chrissy.
Yeah, so community relationships are incredibly fundamental. When I started this work, I established for myself sort of a core set of principles that I wanted to work from, and one of the first of those was prioritize the data needs of the community. Because in terms of both what I'm working on, what I'm advising in terms of direction, if we're working on data problems that aren't a problem for the community, then we're working on the wrong problems, right? We need to be able to connect with both communities and service providers. So when you're a federal agency, who is your community? I mean, that's a lot of levels, right? So I'll give just a case example with respect to one of kind of the areas where we need better data, which is people who are experiencing homelessness. So for instance, what does community engagement look like? Well, for us, part of our community is all the jurisdictions that we work with, right? We need to be able to work effectively with them. So in terms of the data gaps, we were doing a landscape analysis. We went and did in-depth interviews and focus groups with jurisdictional staff. But then part of our community also is healthcare workers and IT providers who are providing these data and these connections. So we included them in the landscape analysis of, why aren't we receiving these data, or why aren't these data being collected? Also, we have to think about community-based organizations, which are incredibly important partners. So we created a technical expert panel, which was primarily leaders from within the space of people experiencing homelessness and the service providers there. And we talked to them about what are your data needs, and had a series of meetings with them to listen to their perspective. And then also including in the community are people with lived experience. So in the case of people with lived experience of homelessness, we're working on tools to better be able to capture someone's housing status in a very well standardized way that can be combined across data sources, which doesn't currently exist. So when we're working on that tool, before field testing that, we had that tool reviewed by people with lived experience of homelessness, as well as kind of subject matter SMEs, because they too are subject matter experts. And then we found some gaps in our landscape analysis with jurisdictions about person-based interviewing and comfort approaching the topic of homelessness. So in the course of that training, both in the design and now we're in the pilot stage, also some of that review, we're looking to groups and people with that lived experience to make sure that we're hitting the right note, that there aren't any major points that we're missing there.
From a CMS perspective, we value two-way engagement with our stakeholders. So as some of you may know, we have the quarterly national stakeholder call. Anytime we have any rulemaking or guidance, we have the open door forum. But in addition, we host listening sessions and roundtables for us to hear more from the communities, from the individuals, from the providers, from the states, and even from other federal agencies, right? We may be all working under the Department of Health and Human Services, but it doesn't mean that we talk to each other every day, right? I probably see, this is my first time meeting Christy, right? I've seen Joanna a couple of times and Kelly via Zoom, but other than that, like, we don't talk that much until we really have to. So the listening sessions and the roundtable is a good opportunity for us. So this past fall and winter, we've reached hundreds of partners. We hosted a session on sickle cell disease, which gave directions to our sickle cell disease action plan, which is posted on our website if you're interested in looking. And that really laid the groundwork for our future outreach and education, as well as collecting the data, improving the quality and access of care to individual with sickle cell disease. It's, we have limited individuals within the country, but when the disease hit, it's really, really major. And so it's important for us to know and understand what is it that we need to do. We also held roundtable discussions focusing on geographically isolated communities, so individuals who live in rural areas, tribal nations, places that you have difficulty accessing, and even our territories. One of the things we realize is, we do oversee the territories for the Medicaid program, the Medicare program, but we don't have data on these territories as we would like to for the states, for the mainland. The most we have from is Puerto Rico, but every territory is different, right? And they all speak different languages, and so how do we capture their needs without the data aspect of it? We work with our Division of Tribal Affairs to stay in touch with our tribal partners and get updated resources in how can we reach out to them to do a better job at addressing their needs. So, for example, one of the issues they mentioned to us is what kind of CMS data I have on individuals who are American Indian and Alaska Native. Sorry, I always have AIAN, so that when I try to spell it out, I got to think about that. And so we don't have that much data on them, right? And what do we have under the Medicare program? What do we have under the Medicaid program? And to the extent that we do, what is it capturing? There's approximately, I think, 574, 76 tribes, and it is important to them that we have data for them. But to be honest, we can barely do it with 50 states in the territories in DC, right? And so we got to figure out what is it that we're lacking and how we can do better. We also have coverage to care health insurance literacy initiatives, where we rely on our community partners to help us assist individuals to get access to care, get their insurance health care coverage. And so it's important for us to have these conversations to see what it is that they're looking for. And the lived experience Christy mentioned, right? Everyone is different. So we want to make sure that we're able to capture the enrollees' needs when they're at the table telling us in terms of what specifically they're looking for and what is it that we can do on our end. To the extent that we can, then we'll try to make that change or collect better data to capture the needs and have a better understanding of their needs.
Thanks. So we're hearing a lot about gaps in data and how do you get to that? So I guess that's another question I'd like to ask of you. And you can tackle that from whatever perspective works well for you. Are there any lessons learned from identifying certain gaps? Are there any solutions that you've been able to put in place to overcome gaps that you had in care? Or are you just still trying to get your hands around what those gaps are?
Yeah, so at ONC, we've been seeing the advancement of EHR adoption, but recognizing that there's still some gaps in EHR adoption when we're looking at small and rural hospitals. Another one is still just some gaps in interoperability, and then as well as patient access. And where we're seeing these disparities is racial and ethnic disparities for patients having access to their information. And again, one of the things that we focus on at ONC is really data standardization, because because we understand that without that standardization, it makes it difficult to actually leverage the health IT. So we've been doing a lot of work in this space with USCDI Plus, and some of our levers that we have. But for ONC, we recognize our role as the coordinator. And so we're really just making this push to use the national data standards that we have, and really the efforts for EHR use in patient portals. So some of the things that we have been working on, if you've heard me speak before, we've had our publication of our SDOH Information Exchange Toolkit. And in addition to that toolkit, we've also followed, I think, between 2022 and 2023, having forums really digging into some of these foundational elements of interoperability for social determinants of health data. One thing, you said kind of lessons learned, we just last week, I think, released a summary report from those forums that we held between 2022 and 2023. So you'll see some lessons learned there. So in addition to that publication, we just have various publications that we put out for ONC, and we're continuously developing resources to provide you with some of these lessons learned as we do our activities. And these resources that we are developing are really focused on supporting our communities. They're informed by our communities. And that's just kind of some of the things that we are working on, in addition to, I can't forget, working with the Gravity Project and the work that they have in data standardization. And again, just going back to some of our grant programs, like our Leading Edge Acceleration programs, really that opportunity for innovation to address some of these gaps that we've seen in data standardization and patients' access to their data.
Kelly.
So I think I've spoken to some of the gaps, including on the sort of social care delivery side. The community-based organizations often don't have a lot of funding, or they don't have a CTO, CDO, CIO to sort of guide the whole enterprise that they have to how do they adopt the right technology, how can it be standards-based, how do they integrate it into workflow. And I think many already have information and referral or assistance technology systems and case management systems. So it's not as though they're without any technology. It's just that they don't have the internal resources or sort of maybe executive leads that would lead a whole portfolio of work like a health system might have, or even an FQHC would potentially have. So that's a recognized need that we need to help community-based organizations of all sizes understand what's important. How should they be capturing their data, using their data? How do they evolve their IT systems over time? And particularly for community care hubs that are going to be the connective tissue between healthcare and community, they need to be able to know how to be a good business associate and integrate with the HIE or other technology vendors, or receive referrals from referral platforms, or be able to have role-based access to Epic or other EHRs if they're receiving referrals from hospitals during a time of transition. So there's a lot of different needs that they need to build out, including the ability to do revenue cycle management. So do they work with a third-party administrator on all their administrative work? How do we help them understand what shared services might be to support their work? So there's a whole spectrum of business requirements that they need to be mindful of, and also understand HIPAA and Part 2 and the many different regulatory compliance issues that they have to negotiate, security requirements that they have to be aware of, privacy requirements. So we are in the process of finalizing a playbook for community care hubs to break all this down for them, to say, here's all the business requirements you should be thinking about if you want to be the entity that's both managing a network of community-based organizations, but also working with your community hospitals and health plans, Medicaid, Medicare health plans, to be able to have the IT capability to integrate and report outcomes over time, to be that HIPAA compliant entity. So we think that might be useful. It's just filling a gap in knowledge and not necessarily having like the in-house expertise to do it all, but also giving them options on here are ways you don't have to do it all in-house. You can have shared services and share that potentially with others. So that's something that's near term that we're doing. We've also worked with others now, ONC and others, to figure out how do we move to more open standards in the INR world. So how do we get to I mentioned this before, how do we get to open taxonomies? It's a gap right now in terms of right now they're all proprietary. But yet if we increasingly want to be addressing health-related social needs, we need to be able to have information referral systems that can be interoperable, share data between themselves, but also all use the same taxonomy. Maybe it'll be implemented slightly differently depending on the needs, but it needs to be a similar taxonomy. So that's a gap that we are still wanting to address. And there's many others, but I'll leave it at that.
Okay.
Well, I'll keep it at kind of the 30,000-foot view gap because there are a lot of smaller technical gaps, but to me, the big gap in public health is going from being able to describe health disparities retrospectively to being able to detect and respond to them in real time and modify our public health interventions in real time to focus on both those existing as well as emerging health disparities. So some of the ways that we're doing that are by improving how we receive data. There's an enterprise data exchange that's like a single front door for CDC and has really increased our efficiency for being able to receive those data. We're also working on moving from more of a program specific, disease specific approach to a more whole of agency, whole of public health approach. Looking at where to integrate AI and large language models into understanding better free text fields, where many times are where some of the data important to social determinants of health are located. And we're just generally working with partners to try to see where we can integrate health information with other important information, such as working with our partners at HUD on homeless management information system and where that can be integrated with things like immunization information systems and other sources.
So in case you're not aware, I want to share that late last year, November, December, HHS released a 5-year data strategy. And this is half the statement of their vision, is that data is available. They hope to make data is available, accessible, timely, equitable, meaningfully usable, and protected in being used by HHS, our partners, and the public to realize HHS mission. So pretty much all of those are our gaps, right? How do we collect better data, but in a way where it's usable by all? And one of the things that CMS has done where we don't have good race and ethnicity data is we developed an imputed algorithm for Medicare race and ethnicity, and we've been using that. We've also, the Medicaid team has also developed something similar. As you all know, there's quality issues with data collected from the states, but we want to make sure that the data is usable. So last year they developed an imputed algorithm, finalized it, and they've been releasing a number of issue briefs, just showing what the data look like. And we're also working something similarly for the marketplace data. We're trying to close the gap in collecting SOCI data. We not only collect data, but we want to make sure that folks know the data we collect and how to use them. So last year, we released a Health Equity Data Access Program grant from our CMS Office of Minority Health. And we granted 3 higher institutions money to pay for access to the seats to get access to CMS data, restricted data. And so we're hoping, putting another plug, that we'll be able to do another round of grant this year, hoping to increase the number of seats for individuals to be able to just purchase the seats, which is pretty costly depending on the data you want. It can range from between 25 to 45 or higher thousand per seat per year. So it is not a cheap price. So a lot of folks are taking advantage and making sure that they want to look at the data, use it, and see how they can share the results of the findings. We're also trying to make sure that we're not increasing the burden as we collect the data, and also be cognizant of the privacy and security issues, right? I'm sure you've heard of this CMS data being hacked, and all our Medicare beneficiary got a letter, and they don't know what it's meant and what they're supposed to do with it. So if we can minimize that, it will ease the, their comfort level and the burden they have to worry about in terms of what we're collecting the data for, how we're using, but also taking into consideration that we're making sure their privacy and security is our number one priority. A lot of the things we're doing is making sure that we have good administrative data, but to what Chrissy mentioned is, AI. How are we making sure that the different algorithms that we're developing to provide good quality of care and access to care are not impacting the underserved population negatively? And then one of that is the best practices to make sure you have the right data for your input into your algorithm. And then it goes back to, well, how do we know we have the right data? And so it's this endless circle of making sure as we are speaking more and more about AI, how do we combine AI and data to make sure that we're doing the right thing? So a lot of that discussion is currently happening at the HHS level, and hopefully we'll be able to share more, as we have our different conferences coming up.
Okay. At this point, I'm going to stop with my questions and give you all a chance to ask questions. I see we've got a hand up right here, got a hand up in the back, and then Linnell, so we'll...
Yeah, one quick question before you get going. Could someone from your panel maybe talk about the White House SDOH report? Because I'm not sure how that fits in with one of your strategies.
Yeah, I was on that interagency policy committee, so I'm happy to speak to it. So the releases of the White House playbook for social determinants of health was in conjunction with the HHS call to action on community partnerships to address health-related social needs. So there was many of us across HHS and HUD and USDA, many departments that worked with the White House that, they were the convener to this work over the last more than 2 years. And so this was a manifestation of all the coordination we've been doing across agencies. And there was really 3 overarching goals or pillars in that plan. The first was around trying to make sure we have more flexible funding for entities to be able to address social determinants of health, be able to finance solutions specifically at an individual need for health-related social needs. So be able to take, ACF block grants, community block grants, to be able to, blend in Medicare, Medicaid, ACL funding as appropriately, or transportation or other housing funding. All that funding needs to be more easily braided together to be able to get to comprehensive solutions and services for individuals. So that was one key theme. How better can we do that? Giving some examples of work that is already ongoing across agencies in that regard. The other is to support backbone organizations, including community care hubs, which I've been talking about, since if we want to improve SDOH and health-related social needs as a part of our health equity portfolio, we really need to have that community infrastructure. We need to have the organizations that can pull everybody together to ensure those successful partnerships, but we also need the governance, and we also need the operational ability to integrate and align health and social care, which is really why we put so much emphasis around community care hubs and the development of them. And then the third pillar is around data interoperability and everything we need to do, which you've been hearing all about. So, I think what we were attempting to do as a broader federal community with that report is to show that these are 3 main strategies. There's a lot of work that fits into those 3 pillars that we're already doing. So we wanted to demonstrate what we're already doing, but there's also a lot yet to be done in all 3 of those areas as well.
Kelly, this is also for you. Can you just quickly describe the difference between the Aging Network's responsibilities, in terms of healthcare and others? Because what we do is take care of people until they're no longer in community. And I think that's a huge difference. It's not a once and done kind of a thing. It's not a shot, it's not this, it's not that. It is the lifetime. And we're the only entity that has that commitment. So I will let you speak to it.
Well, yeah, you're speaking to the value that you bring to the healthcare world generally. That is probably not well understood by many. So if one really great thing about our federal collaboration is that we are bringing light to the important social service programs that have been around for many decades. The Older Americans Act has been around since 1965. It was intended to be a wraparound with Medicare and Medicaid. The Aging Network has been there for 50, 60 years, and many of organizations like yours have been trusted in the community for many, many decades. And you do follow people through their lifespan into their home and provide critical services. And a great example of how we need to be braided. It's not an entitlement program. All the Older Americans Act programs have been set up through different grant funding scenarios. But there's about a 1 in 4 investment where a lot of states and other programs invest in that same infrastructure, but it's intended to serve Medicare beneficiaries, and often really it's dually eligible beneficiaries that you reach so effectively. Because we are, by statute, and now our most recent regulation out last week, charged with really serving those of greatest economic and social need. That is at the heart of what we do. So how to differentiate it? It's a good question. I mean, that is the specialness, if you will, of what you do, right? And what June Simmons does, and many others in the Aging Network that serve over 10 million beneficiaries every year. We now can build on it, right? There's more clarity that we need to wrap around with Medicare and Medicaid. There's more clarity. We have more and more opportunities with HUD. Our partnerships with HUD are so much more mature than they were 3 years ago. It now recently launching an accelerator with the Medicaid 1115, 9 of those states that are focusing on health-related social needs and housing supports. So yeah, I think this is sort of a good time to say, okay, these organizations like yours are out there. You can really build on all your strength to be able to be a really strong partner to the hospitals in Maryland, to the primary care practices in Maryland. Maryland's also just such a great learning laboratory because you have such an advanced waiver and an incredible HIE. So kudos to you for all the great work you're doing. And I think we're going to have hopefully more visibility over time about how does healthcare and social care really align to be able to effectively meet individuals' needs over time.
Good morning. My name's Kendra Wyatt. I'm a community birth provider and came here from World Championship Kansas City Chiefs, by the way. Came in for this. Got to lift that up. Got to lift up Baltimore. Thank you for helping us a long way. I came here to ask you all a question, and I need you to just know some context. I could not be on a more different planet. I am in an EHR that's certified, and I've got Epic and Cerner who are not only faxing records to each other, they're putting them on CDs, 200 pages at a time. So when it comes to maternity health, and I would really like to see us start talking about, if you mention SDOH, talk about pregnant women as an underserved population, and when it comes to high tech, we have a problem, guys. We have not talked about pregnant women. I'm convinced we're scared about abortion. And so we're not doing enough. And very, very simply, OB panel labs. If you have a project and you're looking for something simple that you can implement quickly, optimize on the OB panel. First trimester labs, these are simple labs. Everybody knows what they are, and we all need them. So my question to everybody at the table, with appreciation that pregnant women, the cardiac and the diabetes issue we have when we're pregnant, play out when we're under Medicare, and therefore it's a triple dip with epigenetics, and we still don't know the impact of COVID. That's going on from a PEDS perspective every single day. I would really love to hear from anybody who wants to comment about how we can lean into making a difference with maternal health on both holding the vendors accountable, because that has not been a priority, and when it comes to interoperability. And please help us as providers stop having to read 200 pages of PDFs.
I'd be happy to take that one. So both as a pediatrician and as a mom, certainly maternal child health and the care of pregnant women is incredibly close to my heart. And I think that this, serves to show why community engagement, and specifically looping in not just kind of maybe some of the more traditional ways that has been done at the federal level, but making sure that we are integrating with healthcare providers as well and including them in that conversation. This is why this is so incredibly important, because you can have a picture of how the data flows and all, the data capabilities, but when you are on the ground, and I can speak to this as a clinician as well, when you're on the ground and you're the one who is faced with a patient that might have incredibly complex needs, a pregnant woman, a child with special health care needs, they have a million different prescriptions, and they're being served by, maybe 2 different networks with 2 different systems. I mean, that's where the rubber meets the road, and that's where that level of community engagement and also that knowledge of what are the primary problems needs to be, and the community priorities need to be what's informing our data work. And so, thank you for bringing your perspective there. Excellent.
Our last question. We have one question from our virtual audience on Zoom. How do we ensure all these initiatives and resources complement each other's work and avoid duplicative efforts?
I'll start. So I've been part of an SDOH leadership team at HHS for the last few years. We meet every other week. There's other leaders across CDC and ASPE, which is our policy shop in the Secretary's office, CMS. It's Megan's boss who co-chairs that, from Aditi Malik, along with our policy leadership. So there's many leaders across all the department that are connected on this work, and we do actively talk about, okay, what do we have planned? What should be our priorities? What's the next step? Like we have an SDOH action plan that was intended to have an overarching framework. This is before the before the White House report came out on the playbook. 2 years before that, we had an action plan as an agency. We are finalizing in the process of getting a report together on accomplishments from that action plan. So we're really trying to keep ourselves accountable for what we said we were going to do and now what we're doing. So there's a lot of active sharing, and I would say also on a very practical level, many of us reach out to each other now that we are connected through these sort of coordinating groups. There's a lot of spin-off affinity groups. One affinity group really focused on interoperability and technology that one of Joanna's colleagues leads. So we do our best to try to stay connected on this work. It's a big portfolio, as you're hearing. Just this is a sampling what you're hearing about today. So it's really on us to try to always be looking to be connected. And quite frankly, on a practical level, sometimes it comes down to the people we work with outside. We have some partners in the room that we're actively working with that are working across agencies, and they also help keep this work coordinated because they're funded to do some of that. So it really takes all of us, I think, to stay connected because of the breadth of the work and the complexity of it. We can meet all the time, but still not to be able to adequately understand everything that's going on. So it happens at many levels in government, but I think it also happens through our partners.
In piggybacking what Kelly says, she worked with my boss at the leadership level across ASPE and different agencies, but it's not just at the leadership level. We try to trickle that down to the staff level since we're the one who's collecting the data, write the rules, listening to other people, reading the comments and everything. So we want to make sure that we capture the information and share the information, trickle down, downstream, upstream as much as possible. So one of the things CMS has done in the last few years, we recently revised it to call the Health Equity Collaborative, where it's a forum for us to share information internally with each other in terms of, what the Medicare side has been doing, what the Medicaid side is doing, what HHS ASPE is doing. So to make sure that the information flow and where there is a gap that we need to do better at, then we understand in trying to address those gaps. Or if we have initiative coming down from the department, we know who we need to reach out. It is challenging, to Kelly's point, but we're definitely trying our best in reaching internally within the staff level, across the department, as well as externally to our stakeholders. And we've been working closely with ONC and trying to make sure that where we could align with USCDI, we will do it. There may be a little bit, hurdle here and there, but to the extent that we can continue to have that communication, it is very important.
And I just wanted to mention, as I said, we, again, always pushing for the standards, so always trying to share our standards, but also just from our grants perspective, when we're coming up with these projects and figuring out what to do, we have conversations with our federal agencies to make sure that we're, again, not duplicating efforts for things such as our SDOH toolkit. They are part of those conversations. They are part of those workshops and webinars as well, as we engage our different audiences, just having the conversations of who's going to be at your event, who's going to be at yours, to making sure that our reach extends far and beyond just our groups that we meet with for our workshops and different events.
Thank you. So we are now at time for a break, and hope that you take the time now to network with some of your neighbors in the room, definitely talk with our sponsors out at their tables, and hopefully if our speakers can stick around, if you have more questions for them, they can help answer those. Thanks, everybody, and have a good break.